to everyone, and thanks for giving me this opportunity, of course, from my parent institute as well as the CAHO. And my topic is antibiotic stewardship, and I will always speak on the Indian scenarios because we are no more different from any hospital in India. Unfortunately, we are at the top of the list in the countries where we should not be, and it is with the highest antibiotic resistance. And India leads the world in antibiotic consumption per person. I don't think it is a proud for any Indian doctor or any institute. And if you see, this was 2017. I don't know. I don't have that figure of the 2019. Every year there is a rise in 11% of the increased antibiotic prescription inpatient and 8.5% in a outpatient. So average overall 6% rise in a antibiotic consumption. Where we are heading, we need to intercept, we need to discuss on every platform like this CAHO we are discussing. So what are the reasons? There are so many reasons we always discuss, we talk, but it's a dynamic process. Every weekly you should talk, every monthly you should talk, every year, wherever you get the platform, please discuss the reasons and how to correct that. Like easy access to the medication, self-medication, like someone must have been read again, it was on doctor's name, that Dolo tablet, but 90% of the paracetamol is prescribed on the over the counter. How can be doctor is responsible for promoting or prescribing the Dolo tablet? So that was a completely controversial statement from the media, and again the doctors get defamed. Then there are lack of the up-to-date knowledge. Every fever is not infectious. Every antibiotic is not covering the every organism. There's hardly any update. Even we doctors, after the passing MBBS MD, how many times we re-update our the knowledge about the every medication and the disease process and what's new in that. Then non-availability and non-utilization of the laboratory surveys. Now we only talk about the metropolitan cities, but what about the peripheries? What about the villages? What about the remote possibilities, remote areas where the laboratory facilities are not available? So how can they prescribe the right antibiotic in the right patient at the right time? What the doctor had said already, but then it will be very difficult for them, and they have to use their experience. And again, we landed with the sometimes combination or unnecessary use of the antibiotic, incorrect use of antibiotic. Even we talk less about this thing, but this is the continuous problem. It is evergreen, ever growing problem, I will say, rather than the usual problem. Then where are the control authorities, regulatory authorities? How many times audit happens? Even forget about the government. Why can't we take our part of controlling it? How many times we do audit in our hospitals, in unit, in OPD basis? Where that audits? Have you presented to our institute, our colleagues on such platform? So a lack of the regulatory control is one of the major reasons for the self-medication and unethical commercial practices. Again, it will boils down to the only doctors for this 7 point, which one is the last in the list. And unfortunate, look at this study was we done it in the Indian Society of Critical Care Medicine 4 years back. 4 years back, 4,000 participants case records we have collected across the pan India from the 120 ICUs. And you will surprised to know one of the major finding we came across: 60% of the patient across the Indian ICUs in India, they prescribe the antibiotic without knowing the where is the source and where is the infection. This is a real story, and I'm sure in INDICAP 2 also we have came across the same. So what are the reasons? If you say there is a rule of the 30% of the all hospitalized patients will be given the antibiotic, irrespective whether there is a reason or there is no reason. 30% of the antibiotics are prescribed inappropriately. That means there is a viral pneumonia, like just now in Pune or around is going on H1N1. So they will prescribe the antibiotic. 30% of the surgical prophylaxis. I don't know where is the fear, whether the fear is in a surgeon's mind or patient's mind. Why they prescribe the antibiotic in a continuity for 5 days? 1 or 2 days surgical prophylaxis is okay, or 1 dose or 2 doses prior to the procedure. It depends whether it is a minor or major. 30% of the cost of the pharmacy cost is from the hospital, but I am sure no hospital is interested in earning through the patients not seeing in the well-being. And then 30% of the antibiotic cost can be saved by the stewardship program. And that's what my purpose. And again, it is related with the patient safety. It is nothing but the patient safety. And why antibiotic get misused and overused? duration of therapy, nobody bothers once you start, whether it goes 5 days, 7 days, 10 days. How can not as early? Like you show that knee-jerk reflex to start the antibiotic. Why can't we show that reflex to withdraw that antibiotic? Non-infective syndromes, like sometimes there is a in brain infarct, it may produce the fever. Pulmonary infarct, they may produce the DVT. One of the common cause of the fever is the DVT, not common, but in a Indian setting and ICUs. Treatment of the colonization, you have to see whether they are adequately covered. Suppose there is a urine sample and 10^3 is the this thing, that likely to be colonization. Why you are prescribing the higher antibiotic? So there are so many reasons for the misuse and overuse, and this is not at all what we would like to see. The consumption, see, look at the cephalosporin consumption in 2015. Sorry for updation, but it must have gone to the something 8,000 or 10,000. So naturally you are heading towards antibiotic resistance. So this was actually we published in 2018 in the Indian Journal of Critical Care Medicine regarding the Indian ICU this thing. It was at that time the predominant was a gram negative and the gram positive was only 8.2 and 34% with ESBL. Though it was published in 2018, this was the data of the 2012 to 14. So naturally, in 2020-22, what we are observing, your ESBL rates jump from 31% to 66 to 77%. And your MRSA from 21% to 45. So where we are heading, we are putting our patients in a trouble. We are putting our medical field into the confusion. What to use, when to use, which combination, and how to save. The first thing where we are talking about infection prevention, there has to be the first part is infection prevention, followed by the infection control. But the situation is not good. And the most important part of the antibiotic prescription is how early you are withdrawing. That is a de-escalation, whether it is an OPD basis or it is indoor or in ICU. This was another study in 2018-19 we have done at the international level. India was one of the participants, and we surprised. It includes the Europe plus South Asian as well as the India. Only 16% of the patients in critically ill on duty doctor dare to withdraw or de-escalate the antibiotic. That's what the situation, it's a real ground level situation is this. And then we talk about antibiotic stewardship. So what is antibiotic stewardship? Antibiotic stewardship is nothing but we are just concentrating patient centric, patient care and patient safety. That is what we move around. Whatever the language you put it, but this is at the end of the patient-centric program. Every hospital, every doctor, everybody should be behind to just implement it, and not only implement, follow it on a regular basis and follow the weaknesses in the system and try to correct that. We'll come to that. Then it will reduce definitely your treatment failure, your C. difficile rates, which is one of the quality marker for your performance of the antibiotic stewardship, reduces the resistance, and that's what the ultimate goal. Already we are 71% ESBL and 41% MRSA. We need to be very alert and conscious. So when we talk about antibiotic stewardship, we should talk about what are the limitations at the ground level. I don't want to teach you what is antibiotic stewardship. That is altogether different topic. So what are the problems in India? I am talking about the Asian and the Indian population. Lack of funding, human resources, lack of the information technology, higher priorities, lack of the awareness, and the prescription opposition. I am sure everyone of attending this particular CME must have been gone through this, and one of the common is the prescription opposition. I'm quite sure. Anyone denies, I don't believe on that, because prescription opposition is one of the common. Second is some other higher priorities are for the administrators. Lack of the awareness among the administration. I think these are the prime should be targeted, and then simultaneously we can see how we can proceed with the funding and the rest of the things. But there is a solution. If there are barriers, there has to be the solution. What are the solution? If there's a lack of funding, develop the simple, locally developed clinical protocols. You should not have your protocols who are on the national or Western guidelines. Naturally, they will be the more complicated. There will be the funding will be required. You require the more training doctors, more training, and the sophisticated way of doing. I would prefer to develop the simple, locally developed clinical protocols that will be appreciated by my consultant, my doctors, and the administrators, which will be based on the low-cost diagnostic tool, will be based on the formulary restriction, which will be based on the antibiotic cycling. There are so many things you can do. Please don't cry that the India is a resource limited country. How long we can go on crying India is a resource limited country? India is not now resource limited country. We are running out of for the ideas and that willingness to implement these things. So we believe that we are now the third power in India. Why can't we show it in the medical field? Lack of the human resources. I agree the ID specialists are on the less on the board. I think why can't we share ID specialists? Why we should have the one single ID specialist for an institute? One institute with the ID person with the help of the telemedicine and telecommunication can give a service to the 25-50 hospitals around 100 kilometer by diameter. So that's how you can tie over your own crisis. Then develop definitely courses. Your physicians, promote your physicians to do the ID courses and do the service. So there are the barriers, but there are the solution. You need to find out. Lack of the information technology, again, use the mobile. Nowadays, the mobile, WhatsApp, they can give you the so many applications and you can communicate with each other for the, like we have a communication group in our hospital with the lab, with the drugstore, and we go on sharing. So within minutes, we can come to know the organism. We know the communication. We can, if required, we can call the microbiologist. We can discuss and change our policy. So these are simple solutions. No need to go for the costly or hi-fi communication system. Then higher priorities, create awareness. Fortunately, my medical director is a medical person and she is the organizing secretary. So she is well versed with the overall idea of the antibiotic stewardship and the importance and why we should implement. Those who are non-medicals or those who are not in a regular clinical practice, I think it's a job of the clinician, it's the job of the quality department, it's the job of our clinical pharmacists. We should go and discuss and make them aware. Let them tell that this is going to affect on your reputation of your institute, not my reputation. Of course, my reputation will be less, but the institute is much bigger than me. So suppose somebody say that in Rubiol, in this department, the infection rate is very high, then you are going to lose the patient. That means the institutes are going to lose. So make them sure that they realize the importance of the antibiotic stewardship. Lack of awareness, again, I have covered. Give them the regular presentation, make them the part of your programs, involve them in your day-to-day activity. So they will also feel that yes, this activity is our activity, this activity is mine, and they should get interest into that. Prescription opposition, there are so many ways, but the only best way is communication. Give them the feedback.
Smartphone over smartphone.
So we are talking about antibiotic stewardship. It should not be the only part of the hospital or institute. I'm sure at the national ICMR level, they are doing so many things. And one of them is the National Action Plan. They have developed the 6-stage strategies, where the strategy 1, which they are now putting a lot of efforts on the improve awareness and understanding of the antibiotic stewardship, strengthen the knowledge, evidence-based surveillance, reduce the incidence of the infection through effective infection, optimize the use of the antibiotic agent, promote the investment, and strengthen the leadership quality. So what the strategy 1 should be for everyone, whether you are local, whether one unit or multiple unit or one institute or state or the nation. First thing, develop that awareness, that knowledge about the antibiotic stewardship and antibiotic resistance, antibiotic prevention. So revise professional curriculum of the students. So if you start from the medical field, but it should not be restricted to the medical field, it should reach to the veterinary field, schools. So they should aware that what is mean by antibiotic resistance. Like one of the areas where the maximum antibiotic resistance is developed, because of that develop is a poultry farm. They use colistin, leofloxacin, 4-quinolines for growth of the chickens, and then when we eat those chicken, we are landed with carries the resistant gene. So I think if we restrict them, and you will surprise to know in India.
I'll request all others except for the faculty to mute themselves, please. Sorry, sir. Sorry.
Yeah, it's okay. Regarding the poultry farms, again, we are leading the world. 85% of the poultry farms in India are using the antibiotic. And the first positive move by the government happened in 2019-20, where they banned the colistin in the use of the poultry farm. So you have to start from that. We are only responsible for 10 to 15% of the antibiotic resistance. Then most important strategy, I always tell everyone that collect, analyze, and publish. Unless until you do that, you are not doing your job. You can't say that I am implementing the antibiotic stewardship for last 10 years, 15 years. No, don't restrict it to yourself. Don't restrict it to your own department. Just share with even the other departments in your hospital and go ahead with that. Strategy 3 is infection prevention and control. We should do that at every level. I already explained, from the poultry farm to the your ICU. You should do, the first part is prevention. Our whole medical curriculum is based on the prevention better than treatment. Then the fourth thing, optimizing the antibiotic use in all sectors. I always say that my unit should not be the only controlling the antibiotic resistance. It should start from the OPD. It should start from the ward. It should start from the nearby hospitals who are sending me the patient. So then only it is going to improve. So communication, training, education, sharing data, analyzing your regular data, publishing. It's like a vicious cycle, dynamic process. All the time you should do it. There is no way you can stop it. And strengthening your regulatory framework. The next part is investment. You need to convince your administrators, your stakeholder, invest in a research, invest in a promotion, innovation, leadership. That is the backbone of the antibiotic stewardship. It should not be the domain of the one single doctor. It should not be the domain of the one single unit. It should not be the domain of the one single team. It's a joint work. The team works better. So most important part is, whatever the antibiotic stewardship we are discussing, we should go it in a dynamic process, but somehow it's slow and we need to have a big push for that. But I'm sure every discussion, after every training course, we will be get geared up. So in a nutshell, antibiotic stewardship is nothing but your selection of the appropriate antibiotic in an appropriate patient in an appropriate doses at the right time and how early you withdraw, versus unnecessary antibiotic and increase resistance cost. Who are the stakeholders in the infection control and antibiotic stewardship? There has to be the leader at the center. Whoever the leader you choose, there has to be the pharmacists, microbiologists, infection control committee, information system, and the ID specialists. And they should be allocated their job. They should know that what is their job. They should regularly meet, regularly discuss, regularly implement, find out the weakness in system, again go for the next implementation. That's what we are going to achieve the patient safety in our patient. Thank you.